Let's see. Can you all hear me?
Yes,
Hello?
sir.
Okay, you can see my presentation, no?
Yes, sir.
Okay. All right. So today we will try to discuss certain questions or try to remind us what we have done so far in respiratory physiology. So before we actually go into the questions, there's one important thing I want you to keep it away. Pay attention. So this diagram is one of the most misunderstood diagram. Before we go into the questions, can someone describe what this is? Is it an alveolus, or is it the anatomical representation of the lung, or what is this one? Because if you don't understand this image, some of the diagrams, you won't get the proper meaning from the book. It might look like, that's an easy one. Everybody knows this one. So what does this part here say? Sorry. So what does this part represent? Trachea, or what is this? Anyone?
Conducting airways.
Conducting airways. Anybody else? That's the only answer? Okay, what does this belly represent? Anybody?
Total volume of alveoli which take part in gas exchange.
Total volume of alveoli. Okay. How about let's erase all this. Sorry. What is this? Sorry. What is this membrane over here? Like, so that this one is the alveolar capillary membrane. It's not just the bottom of the lung. Okay. So this is not the lung. This is not the trachea or the conducting air, you can say, but this actually represents the dead space. So it includes all kinds of dead space in this one. So this is the alveolar compartment. So this one is usually the first one is usually about 150 ml in anatomical dead space because you don't have enough physiological dead space. And second one is your alveolar volume, which is about 3 liters roughly. And this is the alveolar capillary membrane. And it is very important to understand this one is alveolar capillary membrane for you to understand the diagrams in the book. Otherwise, you will think, okay, this is the lung, and that's the trachea and the conducting airways, and this is the belly of the lung. So that's not like that. So this third one is the most important. This is the alveolar capillary membrane. And when you mention somewhere over here, when you have put, say, fourth, it's the end capillary blood. So you get pulmonary blood from here, deoxygenated blood, and it goes through the alveolar capillary membrane, and then you end up getting end capillary blood over here. It's extremely important. Say if you draw a shunt or something like that, then you draw something, another vessel like this. So this 4 is the end capillary blood, and 5 will be the arterial blood. So this diagram is extremely important to understand, and then make sure you don't confuse it with some anatomical structure. This is not an anatomical structure. This is a functional representation of the lung or respiratory system, not an anatomical. This one is not the anatomical structure of the conducting airways or the trachea or the place. It's actually dead space. The other one is the alveolar space. Okay. All right. Now we'll go into some important but simple questions first. Explain how partial pressure of oxygen changes from atmosphere down. This is basically the oxygen cascade. Very easy, and everybody knows this one. But when you are asked to draw this one in a viva or some kind of setup, then you should be able to, because this is an important question, an easy question. And if you struggle this one in the viva, so it makes a real difference about the impression you can make to the examiner. And because it's an easy one, everybody will answer. And if you have, say, 20 people coming for the viva, and then you ask the question, so there is probably an entry question for another set of set. And then if you struggle with this one, and then it does not create a good impression on the examiner about you. So it's very important to understand this diagram and whatever how you draw it, and then you should make sure you have done it at least 10 times before you come to the exam. Then you can make a good. So it's very important in the viva, because if you create a bad impression, or in the sense, say, you look like you are struggling just to draw this one or to explain this one, and then it will, although we do not do it like that way, we just have a certain marking scheme, but still the impression sometimes matters when it comes to especially viva. So when you are drawing this one, you should know at the same, if you have done it 10-15 times, then you know, okay, when you draw this one, okay, this is why this value is 150 or 160, or this value is 100 because of this one, rather than just drawing it and so, okay, this is the oxygen cascade. You just draw it and then share. Okay, so I'll give you a couple of minutes without looking at a book or something, and just try to draw this oxygen cascade. At the same time, explain in your mind, or at least just explain why certain values are because of them. What is the explanation you can give to say that certain value is 150? Why is that? Certain value is 100. Why is that? Certain value of 40, whatever. Then you draw it. I'll give you a couple of minutes, and you draw it. We'll come back, and I'll just ask one of you, or you guys, how you come to that conclusion. Okay, 2 minutes, draw it. Okay. Now, so I can't see your answers. So if I'll just try to draw this one on my screen and you explain why it is like that. So this axis, we draw partial pressure of oxygen, and we try to draw what happens. So we start with, you can start with the atmospheric oxygen, or you don't really have to. You can just start with what is inside the upper airways or airway opening, what upper airways will say trachea. So what is the oxygen partial pressure at the trachea, or what we call inspired oxygen tension? Anyone?
150 millimeter mercury.
Okay, what is the reason for 150? So I say 150 over here. 150. Why it is 150?
Due to reduction with saturated vapor pressure of water.
Okay, saturated water vapor pressure at 37 centigrade of body temperature is what?
Yeah, it is 40.
40.
47.
47. Okay. So what is the complete answer? So what you say is correct, but so how do you get that answer? How 150 from your saturated water vapor pressure?
760 minus 47, 21%.
Yeah. So okay, that is also good. So that is another step forward. Now in the exam, so if you want to impress the examiner, what else should be mentioned when you mention this one? Okay, you can say 150 is because of the saturated water vapor pressure. Good answer. And then and somebody says, okay, it's 760 minus 47 into 21%, whatever. So what is the next level thing to mention? Like when you come to the exam, so you guys know all the answers. So there is, most people will know the answer for most of the questions. It all depends on how you express your knowledge. So you know, how confident you are and how many details you include in your answer within that given period. Now, it doesn't matter whether you know. So all what I'm going to go tell today, you know all these facts as facts, but it depends on how you express. Okay, so that 760 minus 47 into 21% is in the middle. So what is the better answer? What else should be mentioned? Why do we reduce this 47? Why can't we include that? Why do we reduce 47 from 760?
Dry gases.
What is the problem with dry gases, wet gases? Good. Tell me, what is the problem with dry gas, wet gas? This is what we have learned in A levels. And this is the problem with our education, because we just learn certain things, but we don't know how to apply it. So you just learn it then and there every time. So why do we reduce the wet component from the dry gases? Anyone?
Follow the gas laws.
Excellent. What gas law? So you are getting there, but it's still. So in the exam, what would you say? Okay, what gas law we are concerned about? Anybody? So it's the Dalton law of partial pressure. Now, when you mention, okay, when you start this one, okay, according to Dalton's law of partial pressure, we have to have only dry gases. It does not apply to vapors. It applies to only dry gas. Ideal gases are dry gases. So we have to make sure that you only consider ideal gas when you do this calculation. So you can mention those words like, according to Dalton law of partial pressure, you can apply this one to dry gases. So we have to subtract the water vapor content. and then you get the partial pressure. So if you mention that one, then that is the complete answer for 150. So as I told you, so everybody will, I mean, all you guys know all the facts I tell you, but the only thing, when you come to the exam, the examiner cannot, he does not know what extent you know in knowledge you have in your brain. So you have to express that one. So if you have done it couple of times, it doesn't take 5 seconds to explain, 10 seconds to explain this sentence. And you can tell this sentence. So you don't have to explain it in detail. But 150, if you just draw 150, somebody drawing just 150 and somebody saying that according to Dalton's law of partial pressure, we have to make sure that we include only in the dry gases. So 150 minus 47 of saturated water pressure at 37 per body temperature, then you get 150. That is the complete answer. So that tells you, that shows you that you know all these things, you know how to express. So that's what I said. So easy question in the exam, the examiners will expect more. So if you ask a difficult question, even if you just mention some kind of, something close to that one, then they'll try to give you marks. But easy ones, that's why they say when you come to the medicine exam, if you get an asthma patient as a long case, and you are very likely to fail the exam, because asthma is a very common problem. So, and then if you don't know about the asthma for a medicine, final year exam or something like that, medicine curriculum, then you are very likely to fail. So people are very worried when they got a common question. So this is one of these common things. So you can fail because you are not very confident, or you don't know how to express these things. That's why anesthesia, you have so many people sitting and only few people get through. So when as important as your studies and everything, these things are also very important. Okay, 150, that's how you get 150. And then even before absorbing anything, this level drops to what at alveoli? What is this level at alveoli?
100.
100. Now, how do you get 100? Why it is 100 there? What happens at alveolar level?
Dilute with carbon dioxide.
Okay. Dilution with carbon dioxide. Okay. Anything else?
The use mixed venous gas, there's a 16%. So mixed with that and reduced to 100.
Mixed venous gas, 16%. What is 16%?
No, the 21% reduced to 16% after consumption. So it mixes the 150.
Okay. So, yeah. So one is oxygen consumption. So when you consume oxygen, like when the oxygen goes into bloodstream, what is level in the alveoli comes down. And then what else is happening? As you said, you get carbon dioxide added to that is one thing. So oxygen consumption and carbon dioxide addition is one thing. The other one is you breathe in and out, you take that carbon dioxide and you bring in fresh gases with oxygen. So ventilation. Basically, if you take about oxygen, it's ventilation and consumption of oxygen. In addition, you add carbon dioxide, it dilutes. That is also true. So this 16%, it's what results in. It's not the cause of, like, the first one we say atmospheric pressure of 760 and the partial pressure of, this FiO2 of 0.21. So if you give oxygen, this one goes up, the 150 will go up if you give oxygen. So the first 150 is because of the atmospheric pressure and the FiO2, the oxygen fraction. So you give oxygen, it goes up, but otherwise in room temperature. The 16% here is just a result of what happens, not the reason. That's not the main cause. Main causes are consumption of oxygen, ventilation are the two main causes, and then the addition of carbon dioxide. So the gas exchange and the ventilation is the reason why you get 100. So that is why we can actually explain it using the alveolar gas equation. PaO2 equals PiO2, which is inspired is 150 minus PaCO2 divided by respiratory quotient. So that's the exchange of oxygen and carbon dioxide R and the PaCO2 value. So you get 150 minus, it's about 40 normal carbon dioxide and 0.8 is your respiratory quotient. What is respiratory quotient? What is this 0.8? What is meant by respiratory quotient?
Production of carbon dioxide to the consumption of oxygen.
Yeah. How do you get 0.8 now? What are the values in how much oxygen is consumed per minute at basal rate? How do, I mean, if you are doing nothing like basal metabolic rate, how much carbon dioxide is produced, how much oxygen is consumed? That is important. This one is still, so you generate about 200 ml of carbon dioxide and you consume 250 ml of oxygen at basal rate. That is why it becomes 0.8. So they say it depends on your diet. If you eat only carbohydrate, then it becomes closer to 1. But the mixed diet, the proteins and the fats and everything will bring it down to 0.8. Anyway, so that is how you explain this 100 over here. So first one, atmospheric pressure and the FiO2 will determine the inspired PO2. And according to Dalton's law of partial pressure, you subtract the water vapor because ideal gases, Avogadro law Dalton law of partial pressure can be applied to dry gases. And then at the alveoli, it drops to 100 because of the oxygen consumption and addition of carbon dioxide or otherwise gas exchange and ventilation. Ventilation will bring oxygen into the alveoli and take away carbon dioxide from. So that is the reason why it is 100. You can explain it using the alveolar gas equation. If the value you get 100, and then you draw certain steps just to show that the oxygen tension can drop to arterial level. When it drops to arterial, there's a slight reduction because of 3 things. What are the 3 things? Diffusion, shunt, and VQ mismatch. So diffusion, shunt, VQ mismatch. Diffusion, shunt, VQ mismatch. And then when it goes to tissues at the mitochondria level, it is very low value. And in Sri Lankan oxygen cascade, we just draw another one to show that at the venous level it is 40. That's not really necessary, but anyway, you can draw that one. But generally, oxygen cascade is this one. So how it flows from the atmosphere down into the mitochondria. So what drives this process? What is the driving force? What are the mechanism involved in oxygen cascade? How does, so it's basically the oxygen is happening only because of the diffusion. So the mitochondrial oxygen tension will determine how much, how this thing for grows because of the simple diffusion. So if you get a dead patient is dead, not brain dead, just completely dead, and you still continue to ventilate that patient, what will be your alveolar oxygen tension? If you keep ventilating a patient, a dead patient, and after 5 minutes, it's completely dead, no production of carbon dioxide, what will be your alveolar oxygen? This 100, what will happen to 100?
Should be increased to 150.
And excellent. So because that is the reason. So if you do not consume oxygen at the tissue level, there is no what we call creation of a gradient. So it keeps increasing up to 150 because nobody is consuming oxygen. So alveolar tension will not fall. nobody is adding carbon dioxide. Whatever the carbon dioxide is being taken away from the ventilation, and then the next one, it comes in, has got almost no carbon dioxide, atmospheric air. So it is filled by the atmospheric air with, so it will be 150. Okay. So this is once again how you describe. So PiO2 is because of atmospheric pressure, and FiO2, alveolar oxygen, because of oxygen consumption and addition of carbon dioxide and ventilation. And then VQ shunt diffusion, you can say it's like drops. You don't have this drops. I mean, it's just a continuous thing, but we just draw it in such a way so that it is. So you can draw the Venus one also in oxygen cascade. Okay, that is about oxygen cascade. As I told you, it's a simple question. Most of the time, it's an entry question to the rest of the other complicated ones. If you don't get this one correct, then what impression you create on the examiners will determine certain level. I mean, although what we say, all this world is not 100% fair. Sometimes, even if you try to recover, but the first, if you create a bad impression about oxygen cascade, the next question, I mean, in practical setup, it will carry onto your marks, although it's not the ideal. Huh? Okay, what are the 4 main causes of hypoxemia? So in the book, we describe 4 main causes. Actually, there are more than 4, but what are the 4 main causes of hypoxemia we talk about? Vidushit, what are the 4 main causes of hypoxemia? Sleeping or something. Chintaka Navaratna. Four main causes of hypoxemia. Or anyone? Madhushi? At least tell one. Kasturi?
Hypoventilation.
Hypoventilation. Okay, good. Hypoventilation. Okay, we'll start writing one by one. Hypoventilation.
Shunts.
What is that?
Shunt.
Shunt.
VQ mismatch.
VQ mismatch. What is the other one? Diffusion. Okay. So, but there is another one called low FiO2. For example, if somebody goes to high altitude, like try to Everest, obviously they will experience hypoxemia. But in practical setup, in clinical situation, we don't consider that very much because everybody is breathing room air, and room air has got this much of oxygen. So it is not included, but it can happen even in clinical setup. If you connect a patient to a ventilator and then you lose oxygen, you still get none of these things, not hypoventilation, it's not shunt, it's not VQ mismatch, not diffusion. So I believe there should be a 5th one, like FiO2. But the book describes only 4. Okay. How would you differentiate these causes? So we'll come to that in a minute. So these are the 4 main causes of hypoxemia. So we'll take one clinical scenario just to understand. So this is a man, maybe middle-aged man. He was taken into the emergency with very unknown intentional overdose of unknown medication. He's drowsy, and he's got a saturation of 83% and slightly tachycardic, and blood pressure is slightly up. So what is the likely mechanism of his hypoxemia? And we have a blood gas done on room air, pH of 7.1, PCO2 of 80, PaO2 of 48, and bicarbonate of 30. So I'm not going to go into details of how to read the blood gas, but you should know roughly. So basically, this patient is acidotic because pH normal only 7.35 to 4.5. So it's low, so it's acidotic. And the carbon dioxide, is it, what has happened to the rest of the, can anyone interpret this blood gas or just tell me what's happening here? Just try to answer because it's okay. I mean, you can get these things wrong, but it's important with them. The more you talk, the more you make mistakes, and then in the exam, you're going to succeed. That's what we want. So you should try. It's okay. We all make mistakes. I know these are not easy sometimes to interpret the respiratory problems. So it's okay to make mistakes. So anybody can suggest what's happening here?
In this patient, his PO2 is low and
Okay.
PaCO2 is high.
Okay.
So there is a I think, intake is low, mean respiratory rate is reduced.
Okay, so you think it is low respiratory rate causing like hypoventilation. So out of the four, like saturation is 83. So we said there are four main causes: hypoventilation, VQ mismatch, shunt, and diffusion. So this could be due to hypoventilation. It could be due to anything. It could be some aspiration of this thing having a shunt or anything. It could be anything. But because he has taken overdose, if we assume that he has taken an overdose, he's hypoventilating. So this is not what we're going to do for patients with this kind of low saturation, but I'm just going to take a clinical scenario, try to explain the physiological things. So don't do whatever I say right now for a patient coming with low saturation. You give like enough oxygen. But so this, because we have high carbon dioxide in the bloodstream, like hypercarbia is usually because of hypoventilation, because ventilation will keep the carbon dioxide usually around 40. That is the only reason why we are breathing 12 breaths per minute. Otherwise, if you only need to say, if there is no carbon dioxide getting into the lung, we don't need to breathe, because whatever the oxygen is being consumed by the alveoli, taken up by the alveoli, you will get more oxygen from the atmosphere. It's because of carbon dioxide we are breathing rate of 12. So when you recover a patient from anesthesia, you might just, if you have given enough oxygen, you can just turn off the ventilation, but still the patient will not desaturate because you have enough oxygen in the lung. But after about a few minutes, and then they start desaturating because of the addition of carbon dioxide, not because of consumption of oxygen. Because carbon dioxide dilute whatever the oxygen in the alveoli, then you need to breathe out that carbon dioxide. Okay, so if you develop high carbon dioxide in the bloodstream, it's because you are not ventilating and washing out that carbon dioxide. So that is the reason. So when you have carbon dioxide going up, like 80 means you have 50% reduction of your ventilation. That is why it is 80. So it's proportional. If you have normally 40 and then now your carbon dioxide is 80, that means you have half the ventilation. Now, PaO2 of 48 is roughly about 82, 84 saturation, because 50 is 85, 90 is 60 PO2, saturation 90. So that is, we know that when saturation is 90, it is, the PaO2 is 60. Okay. What is the PaO2 if the saturation is 50%? Anybody knows? Is that important to know?
26.5.
Excellent. 27 or 27, we call it 26.5. Okay, 27. So that is what we call P50 value. What is the importance of P50 value?
To do
Why
the
do we-
oxygen dissociation curve, 3 point needed.
Sorry?
To draw the oxygen dissociation curve, we need 3 points.
Okay.
So 1 point is P50.
Okay. So that is what for the exam. But what is clinical work? I mean, if you want to draw something, that is the exam point of view. But what is the practical application of P50? If somebody says P50 is 27, so this is how to So somebody describes something happening to the oxygen and he wants to make some kind of clinical data recording about the oxygen visualization curve. Because the curve can be shifted to right and left. And if you just say saturation and this, so you do not know what the position of the curve is. So to tell the position of the curve, if the curve is shifted to the right, then the P50 will be higher. Shifted to the left, P50 will be lower. So P50 is mainly used to explain the position of the curve, whether it is shifted or normal. So if your P50 is 27, that means oxygen curve is not shifted. It is true, whatever you say is also true, because I mean, that is how you draw the curve, but this is to tell the position of the curve. Okay. All right. Now, this patient is having a low saturation. And then the question is, how would supplemental oxygen correct his abnormality? Would it correct? In hypoventilation, if you get a patient with hypoventilation, if they are apneic, it will not, because they are not breathing, they will die soon. But if they are hypoventilating, when you give oxygen, it is very easily corrected. So this is actually hallmark of hypoventilation. The moment you give a little bit of oxygen and the saturation goes back to 100%. And it is contrary to shunt. Like shunt, however much you give oxygen, because shunt is the blood passes without getting oxygenated. I mean, it does not go through the alveolar capillary membrane. So shunted blood is just diverted. So you, whatever the oxygen you give, it does not get in contact with the gas exchange membrane. So shunt is different. But here you give oxygen and the saturation picks up very, very quickly. And so the answer, if it is hypoventilation, yes, supplemental oxygen will easily, quickly correct this problem. How much oxygen would he need to get his saturation to 100%? So just how do you answer that question? How much oxygen do we need? What can anyone explain how to calculate how much oxygen he needs? We don't do this in clinical practice, but just for physiological understanding, what would we use? What equation would we use? So if you want to get 100% saturation, you have to have roughly 100 of, or close to 100 of alveolar oxygen, because in hypoventilation, there's nothing wrong with the lung in the sense drug overdose, this thing, because your alveolar capillary membrane is okay, but it's because for some reason or central nervous system or some other external factors which is reducing his ventilation. The alveolar capillary membrane is normal. There's no problem. No problem with diffusion, VQ mismatch or shunt, but it's simply because he's not breathing enough. In that case, if you have enough oxygen in the alveoli, you will have. But here, because you are adding carbon dioxide and you are not bringing oxygen into the alveoli, so you don't have enough saturation because you don't have enough oxygen in the alveoli. So you get the alveolar oxygen to 100, then you can probably get a saturation of 100%. So how do you get PaO2 of 100 in the alveoli? You can give oxygen. And what percentage? How do you calculate? What?
Alveolar equation.
Alveolar equation. Okay. So alveolar equation, you have PaO2, P capital AO2, that is the 100 what we want. So we can get PaO2 as 100. And PiO2 is, we give oxygen and the FiO2 is the one we want to find out. Okay. And then the carbon dioxide, it is 80, the respiratory quotient 0.8. Okay, I'll give you 2 minutes. Calculate using this equation, calculate how much FiO2 this patient needs. Okay, so use those values. The PaO2 is 100, capital AO2 is 100. PiO2 is the one we want to figure out. And you know how to calculate that one from the atmospheric pressure and the whatever the FiO2 and the water vapor pressure, things like that. And then the PaCO2, the respiratory quotient. Okay, find out what FiO2 this patient needs to get I'll give you 2 minutes. Okay. Anyone can give me the answer? How much?
28%.
Sorry?
28%.
Excellent, excellent. So what you do is 760 760 minus 47 to make it dry gas, and you increase by FiO2, and then minus PaCO2 is 80 divided by 0.8, and this is your PaO2 of 100. So FiO2, this is the only one which we do not know. And then you calculate, you only have to use a calculator or whatever, then you get to 28%. It's about, so if you want to get 28%, so you would, what oxygen device would you use?
White color Venturi.
Okay, you can use Venturi for 28%. Otherwise, if you use nasal prawns, how much oxygen would we use?
2 liters.
Okay, if you use 1 liter, you get 24%. You
24%.
get 2 liters, 28%. Yeah, good. 2 liters. So just 2 liter oxygen from a nasal prawn will get the saturation to 100%. So what is the implication? So that is the reason why we do not send patients from the recovery to the ward when they are on oxygen. So somebody having face mask, 4 liter oxygen, and the recovery is been fine, it's okay, his saturation is 100%, and you take the oxygen out and send the patient to the ward. So on the way, patient can have a cardiac arrest or even, some kind of, because of hypoxemia, if the patient is hypoventilating. So it's important, before you send the patient from the recovery into the wards, you always make sure that you take the oxygen out and look at the, because this will be unmasked. Hypoventilation will be unmasked by giving just a little bit of oxygen. You might say, oh, no, 2 liters only hit here, but he was okay. But it doesn't matter, because even if 2 liters is enough for you to correct 50% reduction in hypoventilation, ventilation. This is very important to understand. So very easily hypoventilation gets corrected. Diffusion we do not generally consider because it's rare. So it's because the allocapillary membrane problems are extremely rare. Like if you have some kind of interstitial lung disease, some kind of significant problems, I don't know, some genetic problem, you won't have a so you would not consider unless the patient has got a clear history indicating a diffusion problem. Even if you have a diffusion problem, the other causes are much more significant. Say emphysema, some kind of lung. So the other causes are much more significant than diffusion itself. So diffusion is not really considered. So it's easy in a clinical situation. You look at the hyperventilation and then you skip the diffusion and you go back to the rest of the two, the AVQ mismatch and the shunt. Okay. So how does shunt affect arterial oxygen and carbon dioxide tension? How to diagnose the presence of shunt? Why is carbon dioxide normal or even low in patient with shunts? Okay, so when you suspect a shunt or you have a patient with shunt, you think it's shunt, and then what would you do in clinical scenario? How to diagnose a shunt if you don't have, say, before you get a cardiology review or echocardiogram or other fancy investigation. If you have a blood gas machine, how would you diagnose the presence of shunt? What do you usually do in clinical setup? You can do a simple test to diagnose shunt or even the percentage in certain situations. And if you have a patient with shunt and you do pre-medication, pre-op assessment, and then if nobody has done anything about this one, then you can do simple blood gas testing. How do you do this one? Diagnose physiologically? Anyone? You must have seen this one. And you give 100% oxygen. You get a blood gas at room air, breathing room air, and you give 100% oxygen, and you do a blood gas when the patient is on 100% oxygen for some time. And then you look at the blood gases. What would you see if you have a shunt? What would you see if you have a shunt in the blood gas? What is the main finding you see? So in a shunt, so this is how you draw. So this one is, what is this one?
Dead space.
Dead space, excellent. So 2 is?
Alveolar space.
Alveolar space. And what is this? 3?
Alveolar capillary membrane.
Excellent. And what is 4? And 5? What is 4?
Capillary end.
N capillary blood. 5 is?
Shunted, mixed vein.
Oh, no, yeah, that's the pulmonary venous blood. Okay, otherwise we say arterial blood. We say arterial blood. This is not the pulmonary artery, but just to show that in the systemic arterial one. So that's how you say. So the 4 is the N capillary one. Okay, in shunted blood, what happens in the shunt? The blood goes through, certain part goes to the gas exchange membrane and certain parts bypasses. So this bypassed amount, depending on its fraction, maybe 10% to 5%, 30%, 40%, and it keeps desaturating. It keeps reducing the oxygen content in the arterial side. End capillary, what we say, it just goes through the lung. So end capillary always has normal amount of oxygen, and then the arterial one, you get a reduction in oxygen content because you keep adding. So if you give oxygen, the oxygen goes only to the ventilated perfused part of this thing, and then it will have the 4. You cannot improve because it's already fully saturated. But the 5 or the arterial is because you always getting a lower amount of oxygen because it keeps mixing with the gas exchange like, shunted blood. That is why, so you give oxygen, but it does not improve your PaO2 to the extent you would expect. Like if you give 100% oxygen, your PaO2 roughly should be around 500, 550, well, close to 600, because you're giving a lot of oxygen and the alveolar capillary membrane is normal and there is no shunt. All the blood goes through the gas exchange membranes, and you should have a very high, like 500 or 550 of PaO2 in arterial blood. So if you do a blood gas on room air and you do with 100% oxygen, you should see above 500 or like a very high level of oxygen in the blood gas. But if you do not see this, if you see with 150 or 100 or 65, 70 of PaO2, even with 100% oxygen, that is definitely a shunt, because that is the only reason, only thing which does not improve with oxygen. All the other causes of hypoxemia, when you give oxygen, your PaO2 rises, although it might take some time, but ultimately it rises. But shunt, because there's no reason why it should improve, because shunted blood does not come in contact with the oxygen you are giving. So it cannot improve. It can improve a certain amount by increasing PaO2 in the arterial, gas exchange side, but it cannot improve significantly because of one reason. What is that reason? Anybody knows why? By giving oxygen, you can increase the flow, but still it keeps, simply because, anybody knows why? Why we cannot improve oxygen like this? It is because of the,
Not involving gas exchange.
sorry?
Not involving gas exchange.
Yeah, that is the reason, but giving oxygen, so you can improve the oxygen level in the flow, like PaO2 in the flow. So you can get flow, like N capillary up to 500. When it comes to, so you mix, why it is causes such a big difference, like PaO2 from 500, 600 to like 80, 70 of low PaO2. What happens there? Why it is causing such a big drop when you mix only 20% of oxygen, blood from the shunt?
Because dilutional part cannot compensate the hemoglobin binding of the shunted blood.
Okay. So in other words, it is the shape of the oxygen dissociation curve. So when you look at this, say, usually you draw the oxygen dissociation curve something like this, because you draw up to 100 of PaO2, and you can get either saturation or content on this side. So I'll take content and then make sure that I draw it up to, if you go up to 500, 600 we'll say. So this is low. But if you shorten it to a shorter version, sorry, then you will see something like this. So this is 600. Okay. This is 100 over here somewhere. And so I'll use the diagram in the book because I'm using with my finger, but my pen is not working. So I'll see, so here, so this is the 600 mark. So this oxygen dissociation curve is slightly different shape because of it's squished into this smaller space. Otherwise, if you take only up to 100, then you will see a normal, something like that. But here you see a squished one because of the scale problem. And then, so now when you look at the diagram, you should know what are these values are. So this one is, what is this one? What is that? That is, so this is alveolar capillary membrane. What is this one?
N capillary.
N capillary blood. So what is this 2?
Systemic arterial blood.
Arterial blood. Now you understand. So this diagram is very important one. Then it makes sense, So one is end capillary. So end capillary, you can go up to 600 of PaO2, PO2. So 600 PO2 is available in the end capillary. But when it comes to arterial, because of the shape of the curve, so if you reduce a small amount, it just reduce a small amount of content from maybe 21 to 20, it's a very small amount of reduction in oxygen content because you're mixing some venous gas. But because of the shape, that's the key thing. So when somebody asks in the exam, if you mention because of the shape of the oxygen distribution curve, the shunt, that is the answer. So if you do not mention the shape of the oxygen, so these are the key things when you answer in the Viva. Because of the shape of the oxygen distribution, even if you don't understand what it means, so you get marks because the examiner will think, okay, he knows about what he's talking about. Because of the shape of the oxygen, if you do not mention the shape of the oxygen curve in a shunt, if you explain this graph, or if you explain this problem, what happens in shunt, then you can compensate by saying so many words. But if you mention the shape of the oxygen distribution curve and this small reduction in oxygen content, so those are the keywords when you answer the question. So make sure that the keywords are mentioned in the answer. Because of the shape of the oxygen distribution curve and slight reduction in oxygen content. Content is important. So that is the reason why, because of the shape, and then your PO2 is brought back to very low value, maybe 70, 80, something like that. So you can actually go up to 100 of PO2, but it's still with 100% oxygen. 100 is not your expected rise in PaO2. This is not the expected rise. We do not expect 100. We expect something close to 500, 600. So expected rise of PO2 is low. I mean, expected rise, we cannot achieve the expected rise in PO2. That is the hallmark in. So although these are common diagrams, common problems, but the words you mention, so you can quickly finish the answer with all the marks if you mention all these things. Because of the shape of the oxygen distribution curve, and with a slight reduction in oxygen content with the shunted blood, slight reduction in oxygen content. Content is important, shape of the curve important, and you cannot get the expected rise of P. So these are the, in a nutshell, how you explain shunt. Now, the person who passes the exam, he masters all these things, what to say, so that you do not have to struggle a lot by using so many words. These are the key things. So if you want to pass the exam, remember these kind of key stuff, and then you make sure that every exam, every question, you try to figure out what is the. And I remember the late Neelika Karunaratne, one of my teachers, and she used to say, even if you don't know, sometimes it's best to. She used to, by heart remember all the sentences from the book. I don't think it's a good idea. I can't do it. If you can remember, that's good. So when you mention that one, that explains the textbooks. They have just, the people who have written textbook, they have been teaching, experimenting, so they have a lot of knowledge, but the sentences are important. So I would say the key terms: shape of the ODC, reduction in oxygen, slight reduction in oxygen content because of the shape, and you cannot achieve the expected rise of PaO2. So that is what I will explain. Anybody who does not understand what I said, anyone who needs more explanation, shunt? Any questions? If you have any question, just type it in and then I'll try to answer. Okay, so that's how the shunt. So shunt is where the blood passes without going through the oxygen, in the gas exchange, and you get shunted blood. So these are anatomical, physiological, physiological shunts in the body is very, very minimal, almost non-existent. So the reduction of arterial oxygen tension from the alveoli oxygen. So we talk about diffusion shunt VQ mismatch. It's not the diffusion, because when you read the diagrams and you look at the diagrams and you see that the oxygen level comes equilibrate with the alveolar one, even so you have seen this 0.75 seconds and 0.25 second by 1/3 of the way through the capillaries, through the alveoli, the oxygen level equilibrates. So diffusion is not the reason why you have a wider AA gradient, or normal AA gradient is about 10, 5, 10, or say in elderly 10, 15. So we'll say 10 of alveolar to arterial oxygen gradient or AA gradient is not due to diffusion or not due to shunt usually, okay? Because we don't have a shunt in a normal patient, but we say Sebacean veins, all these kind of bronchial veins, things like that, they are very, very minimal, almost non-existent. Out of that 10, maybe 1 or 2, you won't significantly. So it is a VQ mismatch. We'll come to it in a minute. So the A gradient, the major part of A gradient is due to VQ mismatch. We did not discuss it yet. Not from the diffusion, not from the hyperventilation, not from shunt. Shunt a small amount, not the major part. Okay, so we will clear all these things. Okay, giving oxygen, 100% oxygen to breathe and checking arterial PO2. So when the PO2 is high, small depression of oxygen causes a large dip in PO2. PO2 does not rise expected level. Chemoreceptor, okay, carbon dioxide, what happens? So when you see low amount of carbon dioxide in your arterial side, so what chemoreceptors are initially, where are the chemoreceptors?
Central
In the
and
body?
peripheral.
Sorry?
Central chemoreceptors and peripheral.
Okay, central chemoreceptors. Central chemoreceptors are sensitive to what? So when you get
PaCO2
carbon dioxide, so
concentration.
they say even if you inject a little bit of carbon dioxide into your carotid, if you are breathing, even in the middle of the breath, if you inject carbon dioxide into carotid arteries, so you get the prolongation of that breath. So carbon dioxide is a very sensitive, and we would think by carbon dioxide crosses this one and then H plus and all kind. So you might think it will take a lot of time. It will take only fraction of a millisecond. Very quickly it responds, and so it activates the chemoreceptors. So when the carbon dioxide goes up, the body can hyperventilate to get rid of carbon dioxide and make sure your arterial carbon dioxide is how many times more soluble than oxygen? Anyone? CO2 is
16,
50 times?
16.
16? Okay. If you look at the carbon dioxide absorption coefficient of oxygen, and oxygen is 0.003. Carbon dioxide is roughly 22 times, but we say 20 times just for to remember it easily, but otherwise it's about 22 times more soluble than oxygen. So carbon dioxide is easy. If you hyperventilate, you can get a normal carbon dioxide, but if the shunt is too large, and this is probably 30% or 40% big shunt, and this is where it becomes refractory hypoxia and respiratory failure. So this is too big. So you cannot, even if you hyperventilate, you're still adding a lot of carbon dioxide into the arterial blood. The shunt is too big. So shunt, so when you talk about ARDS, you have a shunt. And that is how Ashbo, somebody who described ARDS in 1956, he said there is a group of people who are resistant to oxygen. So they have seen most patients, when you give oxygen, they improve, but this group of patients, they do not improve with oxygen. So that is how he coined the term ARDS, acute onset, all this blah, blah, blah thing, because they were resistant, refractory to hypoxemia. By the way, what is hypoxemia and what is hypoxia? What is the difference? Anyone? Hypoxia and hypoxemia?
Hypoxemia means low oxygen tension in blood.
Excellent. Hypoxia?
Hypoxia, it occurs at the tissue level.
Okay, yeah. So hypoxia, okay, that is true. The hypoxia is actually a process how you get low oxygen tension in the tissue level. Hypoxemia is low oxygen tension in the blood. Hypo means low, ox means oxygen, emia means blood. So hypoxemia is low oxygen tension in blood, literally. Hypoxia is actually a process, like, you can get hypoxia, like, low oxygen tension because of anemia. You call it anemic hypoxia. And if the heart does not provide enough oxygen, enough blood flow, you can call it stagnant hypoxia. If there is some kind of toxic thing happens, cytotoxic hypoxia. Hypoxia is actually a process which causes low oxygen tension in the tissue level. But hypoxemia is low oxygen tension in the blood. Okay. So that is about the shunt and oxygen tension. I hope you understood all these things. So shunt. So if you take different, okay. Now this is the normal situation where your PaO2 is 100, PaCO2 is 40, because you are getting 45 of carbon dioxide from the pulmonary artery, and then it's a venous blood you are getting in the pulmonary artery, and then this carbon dioxide diffuses and oxygen diffuses back into this thing. Then you have this normal value. But for some reason, if you keep obstructing the airway and get to a state where you don't have, this is actually in certain parts of the lung in this diagram. So if you get a spot where there is no ventilation happening, so this is a theoretical thing. I mean, in the lung, if you take the whole lung, when you obstruct, there is no gas and they will die, but still in a theoretical way, if you obstruct all the ventilation, so ventilation is 0, you get the normal amount of perfusion. So it looks like it is a shunt. This is called a shunt because the blood does not participate in the gas exchange because there's no ventilation happening. That is why you draw a right ventricle over here in this diagram. And on the other end, if you reduce the blood flow and then completely cut off, so whatever the oxygen coming in, nobody is absorbing oxygen. There's no absorption of oxygen. There's no addition of carbon dioxide because there's no blood flow to that. So that is called a dead space. That is why we draw a dead space like a trachea sign over here. So ventilation VQ is V is normal, Q is 0. Something divided by 0, it becomes infinity. And if 0 is divided by anything, it becomes 0. So VQ can range from 0, which is called a shunt, and the infinity, which is called dead space. So these are separate entities. So you have dead space, you have shunts, and then you have what we call a VQ mismatch. So what is VQ mismatch? Can anyone try to explain the difference between shunt? Because a lot of people think shunt and VQ mismatch, they are the same thing. Anyone try to explain what VQ mismatch is? At least what you know about VQ mismatch? Anybody? Try. So when you try to explain, then even if you make mistakes, then this is where you learn. This is very important in if you want to pass the exam. This will be asked at some point. VQ mismatch is probably the most important thing in respiratory physiology. When it comes to gas exchange, VQ mismatch is the most important. If you don't understand, then if you try now, even if you make a wrong answer and then you feel ashamed, oh, I gave the wrong answer, but you will learn and you will definitely tell the correct answer in the exam. So it's best to try. Anybody who can explain what VQ mismatch is? No one. That is why I said the lectures are very not important. I mean, you just try your best to explain. At the end, it is actually just a waste of time.
In the mismatch, all alveoli getting ventilated and perfusion, but there is an imbalance between.
Okay, that's a good.
But in
Yeah.
shunt, there is only perfusion, there's no ventilation.
Excellent. So what she said is there is no ventilation, but there is perfusion. So the blood goes through a portion of the lung where there is no ventilation happening, so there is no gas section. So you can't get deoxygenated blood heading into the arterial side. In the VQ mismatch, all the alveoli, all the alveoli are getting ventilated and perfused, but there is a mismatch of VQ ratios. That is the answer. Very good. Now, anybody who did not understand, so the next question is, how would you diagnose, differentiate VQ mismatch from the shunt? What is, okay. So we'll just first try to understand people who did not understand. So this, once again, this is not that, this is a beaker representing that thing. So this is not dead space here, because this is not, although it looks similar, this is not the previous diagram we described. This is just a beaker. So don't confuse yourself. And somebody is adding dye, powdered dye into this one, and then it stirs using a stirrer over here, and you get water coming in. This is not the lung, this is not the dead space thing, this is not the alveolar this thing. So what you do is you get water, clean water, like, and then you add dye, and somebody wants to figure out what affects the concentration inside this chamber, concentration of dye. So if you keep adding, people might say, oh, it's the amount of rate of powdered dye added into, yeah, that is true. And then, but if you change the water flow, and it changes the concentration. So it is not simply the water flow rate or simply the dye flow rate, it is the ratio of this one, or the combination of these additions, which determines the same thing in the alveoli. It is ventilation will bring oxygen and take out carbon dioxide, and perfusion will bring carbon dioxide into the alveoli and takes oxygen low, it will take. So that is perfusion and ventilation. If it is matched 1-to-1, then you have a perfect alveoli. So when you take each and every individual alveoli, so they all have different perfusion and ventilation ratios. So what is your alveolar ventilation? If you take tidal volume of 500, so 150 is dead space, 350 is your alveolar ventilation, and you multiply that by 12 breaths per minute, so you get roughly around 4.2 liters of alveolar ventilation, and you have a blood flow of 5 liters per minute, and you divide 4.2 by 5, and you get something around 0.84, something like that, 0.8. So your VQ, this is not respiratory quotient, okay? Although it is 0.8, this is the VQ, normal VQ ratio of the lung. But if you basically have same amount of, each and every alveolar gets the VQ ratio of 1, like, the perfect balance, then you should have a VQ ratio of 1, which is the ideal, which you have no problem. But generally in our body, we do not have that one. What are the reasons? So if you look at the lung, the top part of the lung, does it get more ventilation or less ventilation compared to the bottom part? So ventilation is more in the bottom, but compared to blood flow is actually very high to the bottom because of the gravity. The air is not that heavy, it does not affected by the gravity in a practical sense in a normal lung. But the blood is liquid, so it tends to draw more towards the base of the lung. So the effect of perfusion is more compared to the effect of ventilation. So it's true that you get more ventilation in the base, but compared to blood flow, so here, if you look at the VQ ratios, ventilation is compared to base is less, but still it's very high compared to the perfusion. Perfusion is low in the top part of the lung. So what happens? So you get some amount of ventilation, which brings oxygen because the perfusion is low. So oxygen cannot be, you can't add more oxygen. It is 100% saturated, it is true. Saturation 100%, but the amount of blood is less, so you are not carrying enough oxygen from the ventilation. So you have a higher PaO2, alveolar oxygen, in the top part of the lung, but the blood flow is less. So VQ ratio is high. Remember these things. High VQ ratios at the apex. Those are the key terms. And you explain, otherwise you just write, okay, ventilation. In the exam, you don't have time. Okay, in the ventilation, you have, and then you must remember these figures. You have high VQ ratio in the apex. You have low VQ. What is low VQ ratio? Because you have more ventilation. Yeah, it is true. But compared to the perfusion, you have more perfusion in the bottom part compared to ventilation. So because this is the bottom part is higher, so you have a low VQ alveoli in the bottom part. So this is very important to remember. So high VQ alveoli in the top part, low VQ alveoli in the bottom part. Okay. High VQ alveoli, low VQ alveoli in the bottom part. Now, so all the alveoli are getting ventilated, all the alveoli are getting perfused, but because of this differences in VQ ratios, so this, when this one having low oxygen, but it cannot be compensated by the high VQ, it's because it is already fully saturated, so you cannot saturate more. So it's from the oxygen saturation, hemoglobin, which is collecting more oxygen, not the dissolved one. We just learned in the previous one, dissolved oxygen is 0.0003 into PO2, which is adding around 0.3 compared to almost 20 with the hemoglobin of 50. So this is negligible. So you have to have hemoglobin carrying oxygen to add oxygen. So in the high VQ areas, because you don't have enough blood flow in there, that is high VQ. So that is why, so that cannot add more, that cannot correct the problem over here. So VQ mismatch is a separate entity where when you exaggerate this problem, normally this is about 0.84 VQ ratio, which is basically keeping our PO2 roughly around 97. Ideally speaking, if you, let's say, for example, if you give sevoflurane to a patient and you look at the inspiratory, expiratory, usually your body concentration is more than your expiratory sevoflurane. If you see a sevoflurane of 0.5 or 1, we'll say 1%, and your body has to have more than that one, you have a concentration gradient. That is how it is coming. But with oxygen, your body is having 97, but the expired one is actually more than that. That can be asked in an MCQ. Expired oxygen tension or PO2 is higher than your arterial. That cannot happen in a normal diffusion kind of setup. It's because of this VQ mismatch, because this bottom part, low VQ, cannot be compensated by the high VQ. Even though there is no shunt or no dead space or no other problem, but it's because of the different VQ ratios causing this discrepancy of arterial and the expired. So the VQ mismatch is because of this problem. So normally it is not significant. Normally it is not, we don't call this one a VQ mismatch. I mean, significant VQ mismatch. So this is actually the reason why you have a arterial to alveolar artery gradient of roughly 10, less than 10. This is because of the VQ mismatch. Okay. So here you can see, if you look at the alveoli, I mean alveoli, you will say 100 and then 97, it's about 3. So the normal AA ratio. So this is because of the varying VQ. So imagine something happens. So we'll say we have a patient with bronchial asthma. So what is wrong with the alveolar capillary membrane? Nothing. So they have a problem with airway resistance. And then because of the airway resistance, if you reduce your ventilation to the bottom part, see what will happen. Now you cannot even maintain 89. Now, asthma patient, you might be wondering why is the saturation is low when they don't have a problem with the alveolar capillary membrane, but because of VQ mismatch. It's because when you reduce your airflow to the bottom part of the lung, then you exaggerate the problem at the bottom or base of the lung. So you have COPD, all these patients, or any secretions post-op causing some amount of airflow reduction to the base of the lung, basically, that will exaggerate the existing VQ mismatch into a pathological VQ mismatch, causing desaturation. Okay, out of these causes, VQ mismatch, shunt, diffusion, and hypoventilation, what is the commonest cause of hypoxemia? Anybody? Commonest cause of hypoxemia? We should ask this in an MCQ. Then you will remember. Commonest cause of hypoxemia? This was asked in MCQ, I think. I remember.
VQ mismatch.
Huh?
VQ mismatch.
VQ mismatch. Excellent. So VQ mismatch is the commonest cause, but we haven't even seen VQ mismatch. I mean, you go to ICU and nobody knows about because nobody understands VQ mismatch. That is the reason why. So nobody will know that in bronchial asthma, what you get is a VQ mismatch out of these four causes. It's not diffusion because your alveolar capillary membrane is good. So if you get oxygen in the alveoli, it will go into the bloodstream. And then it's not it can be hypoventilation a little bit. That adds. That is true. So it's hypoventilation. It's possible because you find it difficult to breathe. Okay, that's one reason. And the other thing is it's not a shunt. You don't get shunt in asthma, and it's basically VQ mismatch and a component of hypoventilation. COPD, the same thing. And any secretion postoperative that you see a lot of patients in the ICU, and you suck out secretions and give some oxygen, they're settled. So those are VQ mismatch, but nobody knows. Nobody understands the VQ mismatch, so nobody says, okay, this is a problem with VQ mismatch. But we see them every day without realizing, because we don't know in our physiology. We just know only, okay, atelectasis, because people talk about atelectasis. And you understand what atelectasis is, pneumonia, okay, chest infection. You understand what chest infection is. Because no one understands VQ mismatch, nobody knows this is the commonest cause for hypoxemia. Okay, I hope you understood. Do we see any questions? Okay, what? How to treat minimize shunting? Okay, how to treat minimize shunting? So shunt, there's a question how to treat minimize shunting. So shunt could be due to pulmonary and extrapulmonary. So if it is cardiac, so you can't do anything with the cardiac shunts unless you do some surgery or some other mechanism. The pulmonary shunts. So if you see a collapsed part of the lung, so it all depends on the underlying reason. If you have a lung collapse, say you have right lower lobe collapse or left lung collapse because of you have put the tube in the right main bronchus and the left lung is collapsed. So how do you treat that one will differ from some other causes of shunt. So in that case, you pull the tube out and probably you have to give what we call critical opening pressure. Once the alveoli are open, it's easy to ventilate. So you just give only a couple of centimeters of waterway pressure, and then you can ventilate or patient can breathe well. But once the alveoli is collapsed, then you have to open it. You need a higher pressure, which is called critical opening pressure, and you have to. So what I do usually in the in our Sri Lankan setup, I do it all the time. I've done it so many times in Balapiti Hospital, I remember. So what I ask them to keep the bad lung up, keep the good lung down, because you get better ventilation in the bottom part of the lung. So you rectify, so the blood goes to the ventilated part because the normal lung is at the bottom. And then you put 2 sandbags on the either side of the lung so that all the transpulmonary pressure across the alveoli is minimized. Otherwise, the lower lung, once you give high pressures, the bottom lung can overexpand and rupture. So you make sure that you put 2 either sandbag or something like, or 2 pillows, something like that. And then you apply a higher pressure or higher PEEP, something like that, to open up the collapsed lung. So that is what you can do. Adding a PEEP will minimize intrapulmonary shunting because you open up alveoli and make sure that they are getting ventilated. So in shunt, you have blood flow, no ventilation. So you can improve things like that. There's no one particular way of improving shunt. It's basically what we do is we add, like in ARDS, we add PEEP. We have higher PEEP so that you make sure that alveoli do not collapse during expiration because the outside the alveoli. So we always say transpulmonary pressure across the alveoli to interpleural is the one which causes lung damage. So in ARDS, you have more positive pressures outside. So you have to have a negative pressure of, positive transpulmonary pressure. So normally in breathing, I explained, so your intrapulmonary pressure from -4 to -8, interpleural pressure increases, like more negative, or you can say -5 to -10, for example. So at the end of inspiration, the alveolar pressure is in normal person will be 0 and the interpleural will be -10. So 0 minus -10 becomes +10. So if it is positive, the alveoli is open because it is keeping the alveoli open. But if you have a positive 10 of pressure in ARDS patient and your alveolar pressure, you are breathing room air without getting ventilated, no PEEP, and this will be 0. So 0 minus +10 becomes, what is that? 0 minus +10 becomes -10. So now the alveoli collapses. So you keep a positive pressure inside to prevent alveoli collapsing. So in minimize shunting, so you can add PEEP, which is the most commonest kind of thing, but it all depends on whether it is an extrapulmonary, intrapulmonary. The shunt, what we described, could be extrapulmonary, like cardiac shunt is also shunt. That causes the same problem. Okay. All right. Okay. No pushing to the bottom of the lung, effect of ventilation is less marked compared to perfusion. Much of the oxygen comes from the lower part of the lung. That is important, and it depresses the PO2. Why? Causes both hypoxemia and hypercarbia. But this, how do you correct this one? So if you ventilate, you can reduce the carbon dioxide, and if you add oxygen, this may not instantly, like, hypoventilation, you quickly correct the oxygen, but here with little bit of time, once you ventilate, because every alveoli is getting ventilated, so you can give more oxygen if you increase the FiO2. So if you give 40%, 60% oxygen, and that when you keep ventilating, the patient will get more oxygen at the bottom part of the lung. It will go from 89 to maybe 100, something like that. So you can increase the saturation of this blood coming from the bottom part by giving FiO2, high oxygen. So VQ mismatch can be improved with oxygen, hypoventilation can be improved, diffusion, all these causes can be improved with oxygen, although it will take some time in the VQ mismatch because you need to ventilate and make sure that you replenish all the bottom part with oxygen. It will take a few minutes, so maybe half an hour, something like that. But it ultimately achieves high Fi. If you give 100% oxygen, you achieve certain amount of high PaO2 with the VQ mismatch. Not in the shunt. Like ARDS, you won't achieve that PaO2. Like pulmonary edema, you have fluid filled alveoli causing a shunt because the gases do not touch the capillary membrane because you have water in there. If you have ARDS, you have some exudate. And in those conditions, you have, say, pneumonia, solid lung, and then those are kind of shunts where you do not, the ventilation does not meet the blood flow. But in VQ mismatch, like secretions, you suck out and then you give oxygen, it's sorted out. Asthma, COPD, all these kind of common things, you can improve by giving oxygen. Saturation can be improved. Carbon dioxide, but if you just increase ventilation without adding FiO2, it will not. Because if you add, you will have same PiO2 of 100, I mean the same thing. So by increasing ventilation, simply we can correct the carbon dioxide but not oxygen, because you need to increase the amount of P or partial pressure of oxygen to do that. So these are the chemoreceptors will sense that one and increase. So you will have more breathing and increase work of breathing, but this ventilation is wasted because it will not add any more oxygen by simply increasing ventilation. But if you add oxygen, so you can just say carbon dioxide, when you increase ventilation, the carbon dioxide comes down, you can do that. But then in the oxygen, even if you increase ventilation, so there is a flat portion of the curve, so it will not add any lot of oxygen. So that is, once again, you can say, even if you don't understand shape of the carbon dioxide dissociation curve, shape of oxygen. So those words are important even if you don't understand when you describe these things. So this was asked in one of the exam, I think in 2018, 19, something like that. But anyway, oxygen carbon dioxide diagram, maybe they might ask in the vivas. Can anyone describe what this is? So I will get to, what is this diagram actually? What does this diagram show us? I don't know any clinical value of this one, but what does it show us? What is this diagram? Disha?
Ventilation
Yes,
perfusion
sorry.
ratio.
Yeah, go ahead.
Ventilation ratio.
Ventilation ratios. VQ ratios
Yes, sir.
of? Okay, VQ ratios. So here, what do we have here? What is the shunt or VQ mismatch or dead space? What is this? What is A? Shunt, VQ mismatch, dead space?
Shunt.
Shunt. So shunt, where you have no ventilation, 0, perfusion is good. So you have a 0 over here. So what you do is you take your normal carbon dioxide of 45 and you get a oxygen of 40 here, 45 or 40. So, and you take that value, you draw that value over here. And you take this one. This one is, what is this? What is B? Shunt VQ mismatch, dead space, normal. What is this B? What is B?
Dead space.
Dead space. So dead space, what happens? The oxygen comes in, there is no perfusion happening. So nobody takes off oxygen. So you will still have 150 of this thing, and then carbon dioxide is 0. So you draw that value over here. And your normal one is 100 of PO2 and 40 of carbon dioxide UL. So if you draw a line connecting all these things, so this shows all the alveoli of the lung, all alveoli must fall into one of these. If you take any alveoli, it should be in this curve. You cannot have an alveoli having a PaO2 of 120 and the carbon dioxide of, we'll say, 25. You cannot have anything like that. So all the alveoli falls into this line. That diagram is called oxygen carbon dioxide diagram. So that shows how VQ ratios are distributed in the lung. So this is used to explain certain physiological things. For example, so here the bottom part of the lung falls over here and the top part of the lung or somewhere close over here. So you have this is your normal. But if you hyperventilate or you have a shunt, and then it goes to these directions. But this is the VQ distribution in a normal lung. So in clinical setup, how to differentiate VQ mismatch and shunt? So from the previous one, I have mixed the slides. So when you have a wide AA gradient, so hyperventilation has and the other one I forgot to mention in the hyperventilation is because there is no problem with the alveolar capillary membrane, the AA gradient is normal. All the other causes like shunt, VQ mismatch, and diffusion, all these causes will have a high or wide AA gradient. So hypoventilation is the only one which causes normal AA gradient. All the other causes will improve. So if you have wide A gradient, it could be due to shunt, VQ mismatch, or diffusion. And then VQ mismatch improves with oxygen, but shunt does not improve with oxygen. That's how you differentiate. So if you have a patient in the ICU, you give oxygen, and oxygen, it does not mean that PO2 can go up, but it is not the expected rise of PO2. So in ARDS, when you give oxygen, sometimes you can see saturation from 70s, it can go up to 90 or 92, something like that. But it does not mean, so you say 80% of oxygen, you have a saturation of 93%. That is not the expected rise. If you give 80% oxygen, you should have 100% saturation. So that is shunt. Still, even if saturation is 100%, you need, say, 100% oxygen, and you get saturation of 100, but the PO2 is still 100. That is still a shunt, because with 100% oxygen, you expect the rise of PO2 is not 100. It should be close to 550, 600, something very high value. So that is still a shunt. So that is how you differentiate. You do not get expected rise of PO2 with the shunt and the VQ mismatch. You will get improvement. Anybody knows what venous admixture is? Give me a second. Just give me a minute. Okay. What is venous admixture? What is venous admixture? This is a common question in the Viva. A lot of people get into trouble with this one. Is that so? We talked about dead space. We talked about VQ mismatch. We talked about shunt. What is this one? What is venous admixture? Anyone knows?
Pulmonary venous blood oxygenated ones get mixed with bronchial circulation, and the oxygen tension reduces.
Pulmonary. What did you say? Pulmonary venous
Oxygen
blood.
gets mixed with bronchial circulation, which is deoxygenated, and the oxygen tension in the blood reduces slightly.
That's the physiological shunt you are talking about.
Yes, sir.
Okay. So this is actually venous admixture. We discussed this in shunt. Okay. So you can have a true shunt, like extra pulmonary shunt, where you get in the cardiac system, you get mixed venous blood or the venous blood adding into the arterial one. So that is a true shunt. And there is no, but in the lung, you have certain kind of different other scenarios where you have different VQ ratios, different other causes causing reduction in arterial oxygen tension. So basically, in a pulmonary different kind of shunt, say pneumonia or some kind of other problem. So if you assume this happens as in a true shunt, this is a degree of, so how much, so you try to calculate how much venous blood is needed to cause this drop in PO2. So this is how it happens. So degree of admixture of mixed venous blood that would be required to produce the observed difference between arterial and pulmonary and capillary blood. So these are basically in a shunt. So they just try to calculate how much venous blood required. So basically, you can say this is basically a shunt. This is not a clinical condition. Venous admixture is just try to assess how much venous blood is required to produce this observed difference in. So basically, we use it in shunt. So you can call it a shunt, but venous admixture is just some mathematical way or just kind of explanation or kind of expressing how much venous blood would be required to produce this one. Not the actual amount of mixed venous blood, but calculated amount. So this, as you said, the Thebesian vein, bronchial veins, you just describe, but it can be in any other pathological condition, but when you calculate, we have to have this percentage or this amount. It's a loose term shunt, but not exactly, because it can happen even not in a shunt also. Say a pathological VQ mismatch, you can still talk about venous admixture because you see some kind of reduction in alveolar PO2, and then you calculate. This is not very important how to calculate. This is just says degree of admixture of mixed venous blood that would require to produce the observed difference. I don't think this question will come to exam because I just want to emphasize the theory what we have learned. So you might need this. A lot of people don't do this one in clinical practice. I sometimes do in questionable patients to figure out what is going wrong with certain patients. So this is a patient, COPD, he is okay. It's not acutely ill. He comes to respiratory clinic and somebody does a blood gas and it's breathing room here. He has a PO2 of 50 and a carbon dioxide of 60 millimeters. Now, when you see carbon dioxide of 60, we say, okay, he's hypoventilating. So that is true. So carbon dioxide goes up with hypoventilation, or if you have more alveolar dead space, you can have high carbon dioxide. So in other words, alveolar hypoventilation, you can get carbon dioxide of 60. Now, I told you in COPD or any asthma, or any obstructive airway disease, you can have low ventilation to the bottom part of the lung, exaggerating the VQ mismatch. So is ventilation perfusion inadequately present, or is it purely due to hypoventilation? I'll just give you a couple of minutes, just try to figure out a way to answer this question. This is not a typical exam question, but this is very important. If you understand this one, then you have understood a lot of physiology and you will use it in your clinical practice. But I'll just give you a couple of minutes just to try to figure out how to check whether there is any other VQ inequality. I'll give you a hint, like if it is hypoventilation, then you don't have a wide AA gradient. If it is VQ mismatch, you have a wide AA gradient. That is the key. You need to figure out whether there is an AA gradient in this patient. If you have a high AA gradient, yes, he has VQ inequality. If you have normal A gradient, you don't have it. Try to calculate. Okay, now how do you calculate AA gradient? So we use the alveolar gas equation PaO2 equal PiO2 is within room air 150 minus PaCO2 is 60 divided by 0.8. So when you divide, where's my phone? So we'll take so 60 divided by 0.8 becomes 75. So 150 minus 75 is 75. So your alveolar oxygen should be 75 in this patient. Now arterial oxygen is 50. So there is 75 minus 50 is about 25. Now generally, normally it's about a couple of millimeter mercury, but it can go up to 10, 15. We'll say 15 maximum, but still 25 is more than 50. So you have a wide AA gradient. So in hypoventilation, AA gradient means alveolar to arterial gradient is normal. In all other conditions like VQ mismatch, shunt, diffusion, you have wide AA gradient. So in COPD, we talk about VQ mismatch. If he has a pneumonia, say infective exacerbation, then that's a different story. It could be shunt, because if you have pneumonia, the part of the lung can have no ventilation, and that adds a component of shunt. But in a normally otherwise regular COPD patient, so if you see this blood gas, there is some VQ ventilation perfusion inequality. So we don't need treatment. I just wanted to emphasize how we can use this knowledge to in the questions. No. Okay. Just to emphasize how we can use physiology. So these are may not be